Good evening, everyone. Thank you for joining us. My name is Elliiott with Transform Dental Sleep, and that is
Jason Tierney, also with Transform Dental Sleep.
Thank you so much for joining us tonight. We have a great conversation, an open dialogue with the great Dr. Kent Smith and the wonderful Dr. Erin Elliott. Jason, I'm gonna leave this up to you, bud.
Yeah, before we dive into these bios, I just want to say how honored and humbled I am that both Dr. Elliott and Dr. Smith are here. These two serve as really, sort of the magic portal for so many dentists in dental sleep medicine. So to have them here sharing their time and expertise with us right now is truly a blessing. With that said, Dr. Elliott, you want to share with everybody? They can read the screen, certainly, but you want to share with them the key points about who you are, where you've been, and why you're here to talk to them?
Well, I have been in dentistry for 20 years, and I was this little old general dentist just cruising along in Post Falls, Idaho. And I was at the Idaho State Dental meeting where a sleep physician spoke in the morning and a sleep dentist spoke in the afternoon. And I just knew that I needed to get into this. And that was about 14 years ago. And so I did like any young person at the time would do and went to the internet, and I found this guy, Kent Smith, in Dallas, Texas. And I went to a course to see what it was about. And I was gone after that. I was committed to making this a part of my practice. So I still practice general dentistry, did way too many fillings today, incorporated surgery, and just a busy practice.
And you're an avid pickleball player, yes?
I might be going right after this, yes.
Okay, well, we will make sure we don't go over. Then,
Okay.
So Dr. Smith, not an avid pickleball player that I know of, but you're quite the Renaissance man, an author, an entrepreneur, a dentist. How did you get into this? Why are you here yapping with us?
Well, I was out there lecturing on the circuit, and I saw this enthusiastic Dr. Erin Elliott in the audience, and I thought, gosh, she looks so motivated to move with this. I think I'm going to do sleep because she's so excited.
Yeah.
No, I grew up here in Dallas, Texas, and for those of you who have heard of the TAP appliance in Keith Thornton, this is where he is. And so I started seeing the TAP appliance in my practice back in the late 90s, and I thought, gosh, that looks interesting. So I said, yeah, I've always been fascinated with night and what happens when we go to sleep. Since I was in junior high, I remember thinking those things, and I just thought, I can have an impact on somebody's sleep. So it kind of went from there. I was asked to teach a course in California, and after that, I taught at LVI, and this is kind of it's moved on from there. And I enjoy teaching, I enjoy educating, and that's why I'm here, to help others.
Excellent. Well, certainly you're going to do that today. Before we dive into these questions, though, I want to share a few housekeeping issues. Number one is on your screen, you'll see a chat and a Q&A button. You can submit your questions there. The questions that we're going to walk through with Dr. Elliott and Dr. Smith today are questions that were submitted in advance when you registered. Some of them are kind of an amalgamation of several questions. And as we walk through those, we'll try to tease out some of the more specific details that were asked in those questions. But continue to, if you have follow-up questions, subsequent questions, continue to add them in the chat and the Q&A. And anything that we don't get covered, we'll try to get to it at the end. But we've got to be sure that Dr. Elliott gets to her pickleball. And also, for those of you that are on here and you're only on here for CE, which I'm sure is no one, nonetheless, I'll mention there is a survey that will pop up at the end of the webinar. Be sure to complete that survey, and you will then receive an email at the address that you used to log in today with your CE certificate. That email will come in the next 48 hours. So please don't contact me 10 minutes after this asking for your CE certificate. You will get it in the next 48 hours. With that, without any further ado, Elliiott, you want to hit that first question?
You got it, bud.
So what screening forms and what screening protocols do you use? There's some version of this asked by several people, but age before beauty, we'll start with you, Dr. Smith. What screening forms and protocols do you use?
Well, I'm a little different that I don't do any dentistry. It's like everyone that comes in is primed and ready to go. They have sleep problems, but I will say that, the Epworth is something that I've preached for so many years because it really causes those patients to say, what's this for? Oh, well, we're involved in treating people for sleep. And so it just starts the conversation. And then other than that, your hygienists just have to be trained to look for the signs and symptoms. And then they bring it up to the doctor and kind of go from there. I think those are the two keys.
Okay. And Dr. Elliott, I mean, more so because you are practicing general dentistry most days still and treating sleep patients, what does this look like in your practice?
Honestly, I think the Epworth is worthless, and that's not to take away from Kent, but he would even tell you that most patients don't even admit to being tired, yet they fall asleep when you're like doing fillings. I think people underestimate how tired they are, and as we know, sleep doesn't always show up as how dozy you are. But saying that, to our practice, it really is about the conversation, seeing the signs and symptoms, bringing up like how do you wake up refreshed in the morning? Pretty much everyone on the team is patients. They all wear appliances. Even my partner, if you saw a picture of Dr. Kelly Harness, she's the epitome of health and an athlete and skinny and all those things. And she is an appliance for her upper airway resistance. So everyone has a story. So the biggest impact that is not a piece of paper that we've added, because we don't really use one, it was more adding to the health history and asking has anyone ever told you snore? Do you wear a CPAP? Have you in the past or been told to? And then have you ever had a sleep study or been told to? Notice how I asked those questions though. One thing I learned is you never ask, do you snore? Because the answer is always no. So
Sure.
Has anyone ever told you snore? To us, it's seeing the signs and symptoms. And again, if you see a scalloped tongue and you bring it up to a patient, the scalloped tongue has no impact on their life whatsoever. So the key is to try to uncover how this could be affecting their life. And it just starts the conversation.
So identifying those signs and then asking some questions to identify what issues they are having. Yeah.
And even their medication list starts a conversation too. Oh, so you have high blood pressure, you take over the counter, omeprazole. And did you know that those are linked to how you sleep at night?
Mm-hmm.
Of course, you could just say, well, the American Dental Association told me I had to, so I'm screening for it.
Yeah.
Do you snore?
Yeah.
Actually, in this, I've got a follow-up question to that comment, Dr. Smith. I mean, the American Dental Association does say that, but most dentists don't do that. Give us some illumination about why that is and what, if anything, needs to change there, or what, if anything, needs to happen to change that.
I don't know what you're going to do to change that. I mean, you can't get you can't get physicians to pay attention to sleep, much less dentists. So it's not education either. It's fascinating. There has to be some kind of a motivating factor. They have to have a WIFM principle going on there. If there's nothing, there's
Their
no
own
way
story.
for them to do that.
Just to even screen for it. Like I do have dentists that refer to me because they know, like, I'm not going to steal their patient. I'd say only 20% of our sleep patients, and we have quite a few that come through every week. Only 20% are from our own patients. And I've been out there enough that dentists know that they don't want to deal with medical, but they care enough to, screen for it and talk to them about it.
Sure. And I think, I'm paraphrasing here, and please correct me if I'm wrong, but the ADA statement on this doesn't say that you've got to treat these patients and bill medical insurance and all that. It just says screen these patients for sleep disordered breathing, and then you can determine what happens from there. It can be a referral to one of your offices, right?
Yep.
Okay.
Yeah, so I'm sorry we didn't have I didn't have a you must use this screener, but changing the health history and treating the entire team or their loved ones is a great way.
Great. And the Epworth is very useful and totally useless at the same time. It's great to have disparate opinions. With that said, a question that came through from a number of people were questions about technology. So what technology do you use? Do I have to have a CBCT? Do I need a scanner? What other pieces of equipment might benefit a dental sleep practice? Dr. Elliott, you want to take that one?
Sure. You don't need any of it. However, because I own it, I certainly use them. So we have a scanner entirely dedicated to sleep, so we can do our full arch scans. And then, since I do surgery and implants and stuff, we do a cone beam on every new patient or whenever I feel like I need one. And the CBCT for sleep, I mostly use to check the nasal area. However, prior to cone beam, we treated sleep just fine. But now that I have it, I like to enhance that. Hey, you still may snore. We obviously want to get nasal breathing with every appliance we use. And so there's times that we'll refer or set proper expectations due to what we see in the cone beam. And seeing so many patients from other dentists that don't have cone beam, we catch a lot of pathology that otherwise would have gone unnoticed for a while. So those are kind of the two major ones. I don't know if I can say that we're getting a laser, getting a Celea sleep, and I'm really excited for that. It's as an adjunctive therapy, and we'll be able to use the hard tissue laser for the general dentistry as well as soft tissue. I have a myofunctional therapist in the office, so I'm excited for that technology coming. So stay tuned.
Got it. And Dr. Smith, what about you? What equipment do you use, or what technology do you use in your practice?
Well, I'm going to have to agree with Dr. Elliott here. I would agree that you don't have to have any of this stuff. And same reasons with the scanners and the CBCT that she uses them for. Don't have a laser. I've looked at that in the past. I just haven't ever pulled the trigger on that. If an EMR counts, we use extensively an EMR. That's more software. It's not really equipment or technology. It's technology, I think.
Yeah, sure.
Yeah. And then we use a pharyngometer and rhinometer. Actually, I didn't buy any piece of equipment until I knew there was going to be a good return on investment on whatever I use. And so once I knew that all these things you could code and get paid for by medical insurance, that's when I said, all right, I'm ready to get that piece of technology, because I know too many people that buy technology and just let it sit in the cabinets and never use it. And just don't do that, right?
Sure.
If you're going to get technology, be prepared to use it, know how to code it. Speaking of the pharyngometer is interesting. As Erin probably knows, I didn't used to be a fan of it. And over the years, I've developed to be a pretty good fan. And I have patients, what we do with it, we're looking, it's always a guess, the best position, I guess the position. But honestly, we had a patient today who had tried an appliance before. He said it didn't work. And we said, well, we can use this special equipment that uses acoustic pharyngometry to find a better position, and just convincing the patient that you have a better way then that patient now is moving forward with an appliance, even though an appliance didn't work for him before. So there's lots of ways to use technology. You have to figure out the right way in your own practice to use it. There's benefits to all of it, but you got to use it. And it needs to make sense financially for you too.
Do you feel that with the technology that you are using, both of you, that you just walked through, I mean, are you utilizing its robustness, or are you underutilizing it in any way?
No, like the scanner music that goes, the Prime Scan has like a special music, and oh my gosh, I just love hearing it all over the office because we have 3. And I was like, that's return on investment every time I hear it. The cone beam, absolutely ROI. I'm looking forward to seeing what the laser will do, but it'll absolutely get paid for as well. So I'm one that hates technology. I really do. I just turned 46, but I'm actually a 70-year-old lady when it comes to technology. But I do use it when it makes sense, and all of these things. I probably underutilize the airway program where you can volumize the airway and use it really as a prop. But we haven't found that we've really needed to say, oh, look, your airway's red. We know they're upright and awake, and there's, not a huge or proven correlation yet. However, we just haven't found that we needed it, because it's more about that conversation with the patient than any sort of, prop, like I said.
Well, certainly each of the items, the technological pieces of equipment that you both just mentioned, I know a lot of dentists that harness that technology in their own practices. So it's cool to hear that you're both on the same page. Earlier, you mentioned you made a comment about physicians not always being dialed into sleep. And that brings us to the next question, which is, there were several about this, and I'm going to defer to you first, Dr. Smith, if you don't mind. But the question is, if you can each give 3 must-do activities for maintaining consistent physician referrals. Other than, and this is a follow-up question to that, but other than sleep physicians, which specialties should they target for their marketing? And before you answer that, I think there is, amongst a lot of dentists, there's this misunderstanding that physicians are all just sort of, they're all created equal, and all of these specialties somehow went through a bunch of sleep education, and they're just putting everyone on CPAP because they don't read the papers on oral appliance therapy. And you're Dr. Smith, you're kind of smirking because I'm sure you've heard these kinds of things online or in your courses. So what 3 activities do people have to do to keep those physician referrals coming in? And then who should they target other than sleep doctors to get those referrals in? Dr. Smith.
Yeah, I think maybe the most important thing is to communicate with them. And, this is something that I've always preached as well, and I learned it early on in my sleep career, because one of my early sleep physician referrals came to me because he was referring to somebody else, and they never communicated back to him to tell him what happened with the patient. So every time a physician refers you a patient, and I advocate sending them a letter saying, telling them that they appointed, when they appointed, and then how you ended up treating them. So that's number one, I would say, is letters. Minimizing the cost, I think, is huge. Physicians don't want to send a patient to you and the patient goes back to them and says, that guy was going to charge me $4,000. I can't do that. I've got I live paycheck to paycheck. I can't do that. And a physician's never going to refer you another patient. So keep that coming. Keep them coming, because you're not overcharging their patients. I mean, you've got to make a living with this, obviously, but you've got to figure a way. And that's all about medical insurance. You've got to figure out that piece of the pie, and we'll probably talk about that later.
Mhm.
And then I would say finally offering an array of appliances. Don't just offer one. Don't be a one-trick pony. They appreciate the fact that you're giving patients the options for treatments. And there's not one appliance that works for everybody.
Mhm.
So those would be my big three.
So communicate, minimize cost, and offer multiple solutions as far as devices. What about you, Dr. Elliott?
I'd say number one is that you need as many letters after your name as possible. You must be a diplomat in any academy.
In every
Just,
academy, any and
every
every.
academy.
Make your own.
I'm just kidding. They honestly don't care. All they care about is that you send correspondence. And to add to that, if we call right away, we have a system where we'll call, 3 times. And then if they don't schedule, then we send the doctor a letter to let them know that they didn't, so that we're following through and getting them in fairly quickly, actually. And so being responsive. And then minimizing cost, they first question is not, are you a diplomat? Because they don't even know the American Academy of Dental Sleep Medicine exists. It's, do you bill medical insurance? So it's great when you can say yes. And then third, I would say, I'll tell patients, they're like, this was so fun. They become our friends. We bond with them. I'm like, tell your doctor what a great experience you had here. So I even coach them to kind of report back that we were nice and knew what we were talking about. And they really appreciate when we go over the sleep study, like in person and in detail, and make it personal to them. So there's a few things about physicians. And then secondly, the medical world is very disjointed. You have to go here to go here. So most primary care doctors, their job is just to refer, I feel like. And so I found a few, they're mostly nurse practitioners, and they kind of get sick of the referral to wait, and then the patient gets lost in the system. And so I reassured him. I said, if you refer them over with via fax, because that's the medical world, we will take care of them from beginning to end. You don't have to worry about anything. We'll send letters. We'll take care of them so that's out of your hands. And that includes even sleep testing. And so they really appreciate how efficient we are. We can get them treated within a month versus like 6 months if the patient pursues it and doesn't give up. So being efficient, I think, has been a big benefit. And like I said, nurse practitioners who are functional medicine, psychiatrists are good. Could probably touch more on the psychologist even. I talked to trainers at the gym, like the sky's the limit. Psychiatrists, endocrinologists, people with diabetes, cardiologists are getting on board with AFib patients. So it just doesn't have to be sleep physicians only.
And Dr. Smith, would you anything else there that you'd weigh in as far as other specialties?
All I can do is just copy whatever she just said, because I mean, cardiologists, yeah. I mean, 8-10 years ago, they weren't paying any attention. They're finally paying attention. We get a lot more referrals for AFib and a lot of other things. In fact, honestly, the heart hospital, we have 2 heart hospitals here in the Dallas area. They are my biggest referrer now.
And they didn't ever used to be. You could have 3 heart attacks and they wouldn't care. They wouldn't ask about sleep. But AFib, for some reason, and the other one I had recently too, that the patient could have no symptoms, but they refer them for a sleep test and treatment, is polycythemia. So that's been coming through the last few weeks.
And endocrinology, I didn't think you would mention that, Erin, but yes, endocrinologists are good referral sources, and you don't typically think of that.
What about the patients that were referred to you by a physician and you treat them, and you mentioned letters, Dr. Smith. I mean, how do you manage that relationship long-term from those referred patients? I mean, do you just, as you manage their long-term care, how do you manage that long-term communication? What's the expectation there?
I mean, we don't, honestly, every office is different. In fact, I learned this years ago to keep an Excel spreadsheet about each referral source and how they like to be communicated with and what they wanted. Because some just want to, we have one or two offices that just send the patients to us just to do the study. That's it. And then they want to decide how the patient's treated, which is a little unusual. Most of them refer patients and then they just say, we're good. They're so busy. They're fine if we just take the patient and run with it. We still communicate, but they want us to do everything. And then there are a few that want to get the patient back to do a follow-up study. So there are those, but I don't have anything over like 2, 3, 4 years that I keep communicating with the physician. And maybe I should, but that's not something that we do.
Got it.
I don't go visit anymore. I mean, I hit the pavement early on. I'm really due to do that again, but like there's physicians that I've never even met, and like on the referral it says I am referring to Dr. Erin Elliiott, as she does a lot of these, or she's an expert in this. I'm like, I've never met this person. So it's like word kind of gets around. And so that's why I think just sticking with it, like there's a point where it's like all this, it like seems like it's never going to work, and then the dam bursts and you just kind of get this flow. So don't give up. It's a long runway, but you'll take off.
Got it. And thank you for sharing that. I think that's a crucial message. Something you said a moment ago, though, Dr. Elliott, about reviewing sleep test results with patients.
It's my favorite part.
Yeah, so I think a lot of dentists that I've talked to that are sort of newer to dental sleep, we've got a good mix, an eclectic mix of experience on this webinar tonight. But a lot of these dentists that are newer just make the assumption that the patient all of this was explained to them. And in my experience, that's not the case. You're both shaking your heads, which I think means you agree with me.
They come in not even knowing what sleep apnea is. Like no one's even explained what it is. They're great because they're compliant patients. They just go where they're told, but they don't get talked to about it. So we should do another webinar on sleep study review. But to me, it's like detective work. Like you can put all of this data, all these numbers, and apply it to their story and how it's affecting them. And I do get sleep studies sometimes that are like AHI of 4, and that's it. And so we always look for the hypnogram or something so that we can connect it back a little bit better. But they're even when the patient says, yeah, my doctor went over it, I was like, well, I'm going to go ahead and do that again. And then afterwards, every time they're like, no one ever explained it like that. Like I came in here to get my wife to stop nagging me, and now I know I need to do this for myself. It's affecting my life more than I thought.
Sure. Dr. Smith, you similar?
Yeah, same. Yeah. Sometimes you got to read the patient, because if you've got that type A, just tell me what I got to do next, doc. I don't need all this detail stuff. And then you have the engineers and the accountants, they want to know every single detail. So you just got to read the room when you're going over the study. And that's what really makes our decision on how much detail we go into. But yeah, in general, they love the explanation. And some studies are much better at it than others. I really don't like it when we get these strange studies that come in. You've got to scramble for the data. It's hard to find, and it's not colorful. It just doesn't tell the picture as well.
Okay, got it. Elliott, do you want to go forward 2 slides? I think Elliott might have taken a nap on us. Next, please, Elliott. There we go. So you both sort of scratched the surface on this topic. Dr. Elliott, you talked about the long runway, but I tried dental sleep. It never took off. It put everybody behind. I'm doing general dentistry. I'm not Dr. Smith, where this is all I do. How do you make time to do all this?
Who are you asking first? Me?
I'm at Dr. Elliott. How do you, with a busy restorative practice and treating a lot of sleep patients and playing pickleball, all that, how do you make the time to do all that? Because it just puts everybody behind.
Well, I would find out why you're behind and when you're scheduling them. So when it first became part of our practice, I was like, okay, sleep consults on Thursday afternoons, and I would not schedule patients, restorative patients, so I could focus on it. But the biggest thing was finding one key team member that I worked together with. The person that was in charge. Yes, other people helped, but there was one person, we call him the sleep champion, that like they are in charge of the program. And at this point, I'm a mascot. I'm still part of it, but they do kind of all of the day-to-day stuff. So we did Thursday afternoons, and then it was all day Thursday. And then we'd schedule 9 units. My units are 10 minutes if they already had a sleep study so that we could take records. If they didn't, we scheduled 6, and now we're down to we're down to less time. But my sleep champ, then we would do all day Thursday, and then half of Tuesday I'd have a lower general dentistry goal. And then it became to a point where the sleep champ just had her own column, and I would go in on the consults, and that's about it. And that's how it is today.
That's where it is now. And, Dr. Smith, I'm going to ask you the same question, but a little different. Your practice is really an anomaly. It's a one of one. But you have, I think you shared with me, coming somewhere around 100 employees. Is that, around 100 employees. You actively pursue your hobbies, diving. You've written 2 books, not 1, but 2 books. You've got kids, you've got grandkids. So more from like a career, a work-life balance. How do you make that happen?
I mean, it's a cliche, but you surround yourself with good people and just learn to delegate. There's this great book called Transform Dental Sleep, and there's a chapter called the Juggler. I'm telling you, if you read, there's so many good pearls in that book. I can't remember who wrote it, but the Juggler tells you exactly how to juggle this and delegate and to make it work. There's a lot more in there about delegation too. So I
don't even know how to deliver an appliance, or like technically I do, but I just haven't done it in so many years. And I lost my sleep champ last year. And so I have Lonnie, who started at the end of January. She applied for front desk, but she had orthodontic experience, but didn't want to be chairside full time. I'm like, do I have the job for you? Right. She's a middle-aged woman who didn't even know she struggled with sleep.
Yeah.
And she was on all these medications. And so she saw the light. And I had younger people before, but I'll tell you, this has been a game changer. And she comes in, she goes, everyone says yes, like this is so easy. And I'm like, yeah, you weren't here the years to get to that point, right? To figure out the workflow and all of that. And then I have someone, my biller helps her as well. We're at a point where I could hire another person, or like just kind of stay at this max capacity we have right now. So that's me being a general dentist. 100 employees gives me hives.
I
don't recommend that for anybody.
Got it. Thank you. Thank you. Because I see a bunch of people getting ready to run Indeed at 100 people right now. Really quick, not to get too deep into the weeds right now, but there was a follow-up question. Just if both of you could answer, whoever wants to go, and Dr. Elliott, you go first. How many nights do you have a patient record? How many nights do you want to see for an initial study?
Well, I know the answer should be 2, but we do 1.
Okay. Dr. Smith?
Yeah, we did one forever, but we've just recently transitioned to doing two because the medical practice that we brought into ours has been doing two for years. And I thought, why don't we do two? And they get paid for two from everybody but Cigna. So I thought, okay, we're going to start doing 2 nights. And since we started doing that, patients, they know that that's better. And they appreciate it. They understand why they're doing 2 nights. And sometimes one night has bad data and the second night is good. So it just kind of makes sense, especially if you get paid for it.
So more data
Yeah,
and more collection, win-win.
And I should clarify, we only do a cash fee for a sleep test. We're not billing to medical in our area. And we'll utilize a third-party service who does 2 nights, depending on the insurance. But we kind of do a lot of the sleep test ourselves.
And just to
But
clarify,
we cash fee.
Dr. Elliott, to clarify, when you say you're not billing medical, you mean for the home sleep test?
For the home sleep test,
Okay,
yes.
got it. So Elliott,
But we get a diagnosis from a sleep physician.
So you mentioned Dr. Smith, you mentioned a book and The Juggler. With that said, I want to give credit where credit's due. The name of that chapter is The Struggle of the Juggle. And that's a phrase that I got from Dr. Jason Doucette. And I was at a prosomnus meeting last weekend. Dr. Smith, you were there. And at that meeting, or I was bummed to see that Dr. Doucette was not at that meeting, but he said, I'll see you at the Sleep Roundtable in Dallas. And I have never been to the Sleep Roundtable. I've sent employees there. I've had FOMO, fear of missing out, over the Sleep Roundtable. And I'm jazzed that I'm finally going to be there in October down there in near Dallas. So can you just share a little bit about who's going to be speaking at the Sleep Roundtable and why dentists should check it out?
Yeah, it's just, what we try to make it be, it's sort of opposite of the ADSM meeting where it's all research-based and science-based. And, you need that stuff. You need to be educated, but we try to make it very practical and how to make your practice better and how to treat patients better and how to get them to love you, how to get your physicians to love you, and then billing. Just the things that I know that offices struggle with is what we put into each meeting. And the speakers we choose are those that we think would help best educate the patients or the offices on those struggles.
Sure. So you've got really practical topics, a bevy of different speakers, and not only are you going in the 11th year, but I hear from people that it's a lot of fun at the meeting. I know one year or maybe in multiple years you had a formal ball. So I hear that it's a lot of fun, and I'm looking forward to it. So people should go to sleeproundtable.com. Is that right?
That's it.
And I think
Dr. you're going to say something, yeah?
Yeah, I just think the beautiful thing of that is focus on team. Like if you bring team to AADSM, there's not a whole lot they're going to get out of it. But this is all about, not only bonding, but learning the practical pearls. So it would be a good time.
sleeproundtable.com.
I just put the link in the chat box, and I've been shooting out links throughout the webinar, just letting everybody know. Thanks, Jason.
Thanks, Elliott. Appreciate it.
Oh, my pleasure.
Yeah. And then Dr. Elliott, you as a presenter for 3D dentists, you've got some lectures coming up as well. Do you want to talk about some of those courses and what they entail?
Yeah, I do an intro course. I don't think Kent's teaching that anymore. Very focused on the step-by-step, day-by-day. Again, perfect for team as well, so that you can delegate to them and get everyone involved. So I'll be Seattle this weekend, but in Denver in February, and Raleigh this November. So we have a great time at the 3D Dentist Retreat in Raleigh there, where you get to stay. We all stay in a house together. I beat everyone at ping pong. A lot of bonding outside of the course hours. And so we have a lot of fun.
Excellent. And, I've been to a couple of those courses, and I appreciate your emphasis on pragmatism. There's not like Dr. Smith said, it's not the ADSM where this is high level academia. It's not science. It's now that you've got that, what do you do with it? So it helps bridge that gap between, theory and practice. And I've always had a lot of fun at those meetings. And
well, I learned
somebody's
from the
breaking
best.
into my house right now. Sorry.
Yes, and Dr. Elliott's right. I don't do any of the intro seminars anymore. So
Yeah.
And I started with Ken. He's the man.
So just real quick, can you go to the next slide, Elliott? So real quick, visit 3d-dentist.com, right? Okay. And then next, and sort of the last one we've got here, before we introduce this, I just want to show, I just had somebody to break into my house. And before I call the cops on him, I think I'll introduce him to you. So Matt Allard from Somnomed.
Hi, guys.
He's
Hi,
been
Matt.
at the
Matt.
desk the entire time.
Happy
But-
birthday week, brother. Hi, Erin.
thank you.
Hi.
Oh, dude.
What's up, buddy?
Dr. Elliott just had a birthday,
Happy
and
birthday.
Dr. Smith's got one coming up on Thursday. We'll talk about that more later. But
Love you guys.
the Transform Dental Sleep Symposium is February 2nd and 3rd. Matt, are you going to be there?
Yes, sir. Head sponsor.
Yeah.
Head podcast.
Yeah. So February 2nd and 3rd in Scottsdale, Arizona, we're hosting the Transform Dental Sleep Symposium. And Dr. Smith and Dr. Elliott are among the many, we've got about 20 different presenters. We're going to have lectures, panel discussions, a ton of fun. So everyone from Dr. Smith, Dr. Elliott, to some real team-centric presentations by Angela Koleski is going to focus on the ins and outs of exactly how to market to physicians. I mean, that's all she does for a living. And she's going to talk about the not so sexy nitty gritty of exactly how she does it. But that way you bring your team and they'll walk away with a ton of actionable pearls. Dr. Cho on pediatric OSA, Dr. Lehman on her transition from restorative dentistry to sleep-only practice. We've got a couple of, actually multiple physicians. So we've got, kind of a veritable who's who of dental sleep medicine. And that's, again, February 2nd and 3rd in Scottsdale. You can learn more by visiting TDS, as in Transform Dental Sleep, tdssymposium.com. And like each of the meetings that Dr. Smith and Dr. Elliott will be presenting at on their own, this is going to be fun. It's going to be informative. And we think you should just make it a hat trick and go to all 3 meetings. But
Sign up before August 31st.
Sign up before August 31st. Prices increase $100. You're going to come anyway. You might as well save $100 for each person. And then I mentioned some books. Or I mentioned Dr. Smith has written 2 books. One of them is there on the right, Goodbye, Good Night. I've got a copy of it right over here. And I failed to get it signed when we were in San Francisco. I'm embarrassed. I'm bummed. So I have to come to the Sleep Roundtable just to get a signed copy. But you can get your own copy. You should get your own copy on Amazon. And Dr. Smith, with a name like Goodbye, Good Night, one might think that this is about dental sleep medicine. They'd be wrong. What is this book about?
Yeah, it's a mystery. It's fiction. It's all fiction. It's all a lie. But no, it's the world is gradually developing insomnia in a certain age group, and no one can figure out why. And they can't sleep anymore, and it's a secret. I can't tell you why. So
right.
You just have to read it.
And are there any real characters or characters based on real people in the book?
I have to say, any resemblance to anyone in
I hope you've got the disclaimer in there.
Yes, I do. It's kind of weird because you read books, fiction books, and they'll say that, and they'll mention like Allen Iverson in the book. You know, it's fascinating that it's just boilerplate, right?
Sure.
Like, yes, of course, I mentioned some names of some people that Jason is very familiar with, and yeah, it's part of the book. There's a scene in Dr. Lehman's office.
Yes. So Elliot's dropped a link to.
I keep dropping links. I keep dropping links and all this
Elliot's
stuff.
dropped a link to the book in the chat, but there's Dr. Smith and I. We're fighting with Licia, trying to get her to pick whose book she likes more, Dr. Smith's or Transform Dental Sleep. I say, why choose? It can be and. So pick both. Pick up.
Because she's in both books.
She is in both books. Yes.
That is true.
My
Yes.
favorite picture of the whole thing. Let's go, Jason.
All right. So I'm going to ask, we're going to split this one up if it's okay. Let's go with Dr. Elliott. If you can take two, Dr. Smith, you can piggyback on with the third one. What are 3 tips for a successful sleep consultation to get the patient to move forward with treatment? Dr. Elliott.
Don't over-educate. It's about getting the patient talking. Find out. So I'm going to say the top tip, if I have to put it in one sentence, is discover their chief complaint. What brought them in?
Okay. Find out why they really came there and
What's motivating them.
and educate on that, not everything else.
To me, like, it's not, when you say educate, to me, that's the dentist talking and the patient not listening. Like, this cliche again, there's a reason why we have 2 of these and 1 of these.
Sure. What about you, Dr. Smith? What's one top tip there?
Well, I mean, aside from cost, I mean, obviously, you know, patients do make decisions by cost sometimes, and it's frustrating. I wish every patient could afford whatever you charge, but in reality, that's not true. So, but that's kind of a known. I think one big thing with me is offering patients 2 choices, always 2 choices. So that could be between an appliance and CPAP. It could be between appliance and surgery if they hated CPAP. If they know they want an appliance, it's between 2 appliances. Always 2, always 2. If you try to push them in one direction, they push back. And then if they choose something, they're more likely to wear it, to live it, and to
not complain about it.
Yeah, they made that. You made this choice, live with it.
Yeah. But really, the most important thing that you can do, the most important way that you can get patients to go forward with treatment is to read Licia's chapter.
Oh,
that chapter was my favorite chapter in your entire book. And I think I've told you that before, but she addresses this very question and this very problem. She's a master at it.
She is. Yeah, they've got almost everyone says yes, and they love what they do there. And their patients love them for what they do. Yeah, for sure. I touched on this a little bit, or I broached this earlier, but when we talked about long-term treatment, how do you maintain the trust of referring physicians when oral appliance therapy fails? Why don't they? You don't normalize the AHI or get the desired results. The patient doesn't say, I woke up feeling like $1 trillion. How do you earn the trust so that that physician continues to send patients to you? We'll start with you, Dr. Smith.
I think you've got to communicate the failures. If you tell them about your failures and you send them a letter saying, the patient just couldn't live with their appliance. They struggled with it. Their gag reflex was too much. We only got their AHI down to 14, and I know you like it below 5, whatever that letter says. As long as you tell them about your failures, they will believe you in other areas as well, and they'll trust you.
Yeah, so I mean, that's really just kind of a core of interpersonal relationship skills and communication, right? It's not specific to dental sleep medicine. Communicate, admit when things didn't go according to plan, and that'll earn the trust of others. Yes.
Yeah.
And
And by the way, the sleep physician, if you did fail, they're the ones that want to be the ones that refer then for surgery or for something else, right? So that's something I learned early on too. If someone sends a patient to you, you don't send them to somebody else. It's that referring physician that should be doing it.
got it. Got it. Dr. Elliott, anything you want to add to that?
Yeah, the frustrating thing is sometimes you don't know when the patient stops wearing it. Like, I'll have patients come in for recare, and I'm like sometimes afraid to ask because I haven't seen them in a while. It's like, so how's the appliance? Oh my gosh, like, what are you talking about? I wear it every night. And then some, like, if they're not wearing it, they're not going to tell you that either. So there's times that the patient gets dropped without us knowing. I wish I was as good as Kent with recare, chasing down those annual recares, but I make sure that we tell them they should follow up every year, especially before the 3-year warranty on the appliance is up. So if they don't come in, we don't really get chasing them. So I would say I'm not the best at that, but I also wish I could just pick up the phone or text the doctor and say, hey, this one's not working out, but we send a letter, or I'll refer the patient.
Got it.
And is because we're type A, right? Dentists. It's like, should I give the patient their money back? They're not wearing it. I'm like, does the ENT that did a UPPP that never worked and made them worse, like, lose sleep? No, like,
Well, and
it's medicine.
Whether they lose sleep or not, they certainly don't refund the money.
No.
Yeah. Okay. Dr. Smith, when we were in San Francisco, in one of your lectures, you mentioned that you have physicians and nurse practitioners working in your office. It's really a unique situation. Can you just spend, a quick minute on the pros and cons there, please?
Yeah, I don't want to spend too much time because most people aren't going to do this, but honestly, there are far more pros than cons. It's just more full service. You can offer CPAPs. And honestly, when you get that patient where the appliance doesn't work as well, if I made enough money on the appliance, sometimes we'll give them a CPAP, and that makes them happy again, right? Because it's all about social media, right? But with physicians, they can write the prescriptions for us. We don't have to, and Erin knows the problem with having to get physicians to write prescriptions for you and to get those pre-study clinical notes. We can't hand out studies to Medicare patients, but since we have physicians here, now we can hand out studies to Medicare patients. We can market for insomnia treatment. And so that 90% of insomnic episodes are related to a breathing problem. So someone comes in with insomnia, they get a sleep study. Many times that patient turns into an apnea patient. We can treat them for apnea. But, they read studies for us. It's just like all the things that you can't do in your practice, we can now do. So many more pros than cons. There are some cons, but we'll talk about that later.
All right, we'll say that for another time. Got it. Dr. Elliott, how can people get arms like you? They want to know.
I don't. Yeah, I do lift, but not CrossFit.
Okay.
I would have told you that already.
Yes. So several people asked this question. How do I manage a posterior open bite that developed after appliance use? What's your go-to technique there, Dr. Smith?
I make it their decision. I say, when we talk to them, but believe me, we tell them this can happen before we ever move forward with treatment. You have to tell people this, and you put it in the consent form. They sign that. They know it can happen. But I tell them, I can't be there every morning to check your bite for you. You have to check your bite to make sure you get your teeth back together. And if you decide that your bite changes, it's going to be your choice. Do you understand that?
Mhm.
And they say, well, yeah, how often does that happen? And I say, well, it hasn't happened to any patient of mine when it wasn't their choice.
Mm.
So when it's their choice to let their bite change, then they can decide to get orthodontic treatment, to live with it. I have so many bite changes that patients just don't care.
Mm.
They would rather be sleeping well, have their bed partner not nudging them, and the kids not making fun of them. It's just a much better life for them. And when I say, are you able to eat okay? And then they always say, does it look like it? Of course,
Yeah.
because most of them are not as thin as Dr. Elliott here.
So when a patient, so Dr. Elliott, when a patient comes into your practice and says, hey, I can't chew linguine with my back teeth anymore, you don't just say, oh, you don't go into a panic and turn red and get sweaty and refund their money?
I do, because I'm like, do you know how many carbs are in that? No, I'm just kidding. I eat carbs. No, usually, so my informed consent conversation is like, I don't go into the nitty gritty detail. Your joint may flare up and you may, it's essentially, the good news is that an oral appliance is not a pill or surgery. And they're kind of like, they like that because everyone knows the pill commercial and all of the side effects. I said the one big side effect we talk about is the potential for a bite change. Your jaw is postured forward at night, your muscles relax. So in the morning, your bite's going to feel a little bit different. We're going to give you a chew toy. That's what we've resorted to calling it in Idaho. Maybe this little morning exerciser so that you can reactivate the muscles, move the fluid out of the joint, and get your bite back to where it was. I said in about 17% of the time, there is a time where your bite doesn't fully come back. And if it happens, you won't look like a bulldog because that's what the ladies care about, and you won't miss a meal because that's what the men care about. And then they usually say, well, I could probably use that.
Yeah.
And I said, if it does happen, because I see so many people from other dentists, just like Dr. Smith, I say, your dentist may be like, ah,
Right.
but it's kind of like your bite being a little bit different or sleeping really well at night. And they're like, oh yeah, like it's no brainer what I choose.
Sure.
So if it does happen though, for some practical tools, first, they're probably not using the chew toy properly or at all, but I'll give them 3 weeks and we'll add some exercises. So Dan Taché is a master at this. He thinks that, the lateral pterygoids are the instigator. It's just no one wants to stretch them because it hurts too much. And so we give them this worksheet of exercises to really hit it home. Sometimes I'll go and get a hard morning occlusal guide from ProSomnus, more than just the AM aligner with their original bite, and we'll work towards that. And then there's like some tools with like a little mouth guard material, little rectangle to get the chin back. So we'll give them a chance for that. And then ultimately it's like we get it back. And then I always lead with, well, let's get you on CPAP. And then your bite will go back. And they're like, oh, no, it doesn't bother me that much.
Oh, I'm good.
I should have mentioned that at first. So
Yeah.
we try to get it back. I do not equilibrate unless I absolutely have to after all this has failed. And even then, it's not to get their bite back. It's to find a more comfortable home.
Got it.
And that's maybe twice a year. And there's one time where a woman absolutely refused to go to CPAP, could not tolerate her posterior bite, and we sat there in an impasse. I'm like, well, what do you want me to do? So I made her an LVI type splint to her new deprogrammed position. And it's like this retainer she wears that has teeth, like it's a composite overlay that she wears, and she freaking loves it. So that was a more severe posterior open bite, and it solved the problem.
And that happened one time and
One time.
Future.
Yeah.
I've done that one time too, and the patient loved it. Yep.
Got it.
That's so funny.
Yeah, I know.
So this question, because I want to be mindful of time, we're going to skip this right now. And it's a question that almost everyone had. There are probably 25 questions about insurance. That's a deep topic. now is probably not the time. However, we'll mention in a moment on our next webinar, it's going to focus largely on medical insurance with Randy Curran. So we'll talk about that more next time. I'm sorry to disappoint anyone, but we want to be mindful of everybody's time. And we've had so much information being bandied about today.
And the first 3 hours on Thursday afternoon of my roundtable is all about billing.
And where do they go to register?
LeapRoundtable.com. Yep, it's A to Z billing, Medicare. It's in Q&A panel, everything. So it's all about insurance.
It
Get
takes
signed up.
tenacity. Tenacity, that's the word.
Yes. So with this question, Elliott's just put that in there again, sleeproundtable.com. I'm going to go with you, Dr. Elliott. Because I know this is something we've talked about a lot and I've seen you lecture about extensively. How do I get my team to buy into sleep and do more of the heavy lifting? Because you're busy. So you touched on it a little bit. Can you just expound on it for a good 60 seconds?
Less than that. It's test the team. Everyone's going to have a personal story, even their family members, if it's not them. And don't judge a book by its cover. It could be any of them. Yeah, like the most petite person in our office is the one that's benefiting the most. How do I get them to do the heavy lifting? I find someone that cares and is passionate about this. Yeah. Oh, and again, to test their bed partners, even if they have multiple ones, all the better.
All right. So multiple units then. We got to, and then would you add anything? You've got a huge team, Dr. Smith. Would you add anything to that as far as delegation is concerned?
I mean, I would just have them read page 61 in Transform Dental Sleep Medicine. That's going to tell them a lot. So if you guys haven't read that book, I'm serious. Jason did not tell me. He did not tell me to do this.
Literally LOL. It's awesome.
It's fantastic. And
he's my favorite author, hands down.
It is. You got to read it, guys, if you haven't.
Yeah. Read the book. Okay, fine. I'll say it. Fine.
I've been messaging people just that I know and saying, hey, how are you? And one of our friends, and I think he's in PA, Dr. Blanton, said, hey, how's it going? He goes, hey,
Tennessee.
I sold my practice. Oh, wait, Tennessee. That's right.
The accent gives them away.
I sold my practice, blah, blah, blah. I'm just here to learn. I do sleep only. I'm here to learn from you all the systems and protocols. And I literally, I'm typing, check out Jason's book, legit. So just throwing that out there.
All right, cool.
Let's go, Jason. Your favorite
Quick
part of the webinar.
Okay, we're going to start with you, Dr. Elliott. I'm going to ask a question. You've got a half a second to answer. You ready? And go. How'd you feel the first time you sent one of your kids off to college?
Excited for them. Not
Beautiful.
To get him out of the house, but I'm excited for him.
All right, next we've got Dr. Smith. Rank your satisfaction with your practice 1 to 10. 10 is the highest.
9.5.
What needs to change to make it a 10?
Yeah, it'll never be a 10.
Why not an 8.5?
Well, because you got to do some comparisons to other practices, and I don't know another practice like ours, so I've got to give myself a 9.5.
Constant and never-ending improvement.
Yes. All right. Next, Dr. Smith. Your favorite city in the world to travel to?
Nauvoo, Fiji.
Why?
Because of the beauty and the scuba diving. It's unmatched.
Got it. Everybody put that on your bucket list. Dr. Elliott, number 4, 1 DSM Pearl for everyone, regardless of their experience level. You've got one. What's one?
Oh my gosh.
You want to impart on the world?
Find your why.
Find your why. It's a good one. Starts there. Okay, what do we have next, Elias? We'll go with Dr. Smith. What is one thing that everyone should do while in Scottsdale for the Transform Dental Sleep Symposium?
See my 1-year-old granddaughter.
Love it. Elias, what do we got next?
Finish it off for us, Jason.
Transform Dental Sleep Symposium, February 2nd and 3rd, 2024. Visit tdssymposium.com to get registered. and we will see you there.
Bring your paddle if you play.
Yes, bring your
You
paddle.
know.
Our
I'm
next
bringing mine,
webinar.
Erin. Bringing mine.
Yes, these webinars are typically bi-weekly. We're actually going to skip a week because of the holiday, the first week of September. And on Tuesday, September 12th, we're going to have Max Kerr and Randy Curran, and focusing on dental sleep systems. So everything from billing systems to just reproducible practices and protocols inside the dental sleep office. So you can register for that. There will be a link to it with your CE certificate so that you can get registered, but we hope to see you there, and we will dive deep into medical billing. With that said, we have a ton of questions. I've tried to intersperse them throughout, but if we can just spend, I want to be mindful of everybody's time. If we can spend 4 minutes running through a few of these questions, if that's okay with you all.
Sure.
Do you bill for sleep titration tests?
I do. I know Dr. Elliott doesn't bill for any studies. So, oh,
Yeah.
you mean the patient? Now, we bill medical.
Oh,
Is that,
so-
that's the question.
Okay, so to get technical, when we do an out-of-pocket estimate, we know what they're going to pay on E0486, and we assume, because we're still kind of out of network with a lot of medical insurances, that the cone beam is going to be billed through the out-of-network benefits. So our cone beam's $150, and then our follow-up sleep test is $100. So what we do is we take what their out-of-pocket will be for the appliance and add $250 to the estimate. So they're basically paying cash on the back end, but we're collecting it up front. Because then they'll be like, oh, well, I don't want that test or want that cone beam. So yeah.
Got it.
Hopefully that made sense.
It made sense. And then another question, and this was a common one before the meeting as well. I'll just ask you all if you want to, if you're comfortable answering this. They want to know, what appliances do you use most often? Can you just maybe give us the top 2 or 3 that you use most frequently?
Yeah.
Prosomnus. I'm not in Texas where you get but Panthera and Prosomnus. Texas is a different story because you're in network allowable so poor.
Yes. Yeah, Prosomnus and Serena Elevate are probably the top 2, and then Somnomed, Avant. Those are the top 3.
Okay, got it. And then Dr. O.
I use Somnomed too, by the way, for a dentist area.
Dr. O submitted a comment that I think is worthy of mentioning. It says, tenacity is correct. I also have both books mentioned and reading concurrently. Hopefully I won't get confused what is real and what is fiction. Yeah. So, with that, we should jump off. You've got pickleball to play, and everyone's was kind enough to share this time with us tonight, and really appreciate you all. I hope that you learned something, and most important, I hope that you take what you've learned and you then take some action. You put it to work, and you go and you help more people, you help more patients, and you grow your practice as a result of it. So
I'm excited to share with you at the Transform Dental Sleep Symposium some of my marketing, some of the hurdles and what to do to overcome them.
Excellent. 3d-dentist.com to find out more about Dr. Elliott's sleep implementation courses. Go to sleeproundtable.com to get signed up for Dr. Smith's annual event. And again, tdssymposium.com to register for the Transform Dental Sleep Symposium in Scottsdale on February 2nd and 3rd. And on that note, I've got a bunch of people waiting for me for dinner. You've got pickleball to play. You've got, I don't know, diving or, reinvent the wheel or whatever you're going to do tonight. So we'll let you go. And thanks again, everyone, for being here. We really appreciate your commitment to the profession and to your patients. So thank you, Elliott, Dr. Smith, Dr. Elliott. I love you all. Thank you.
Thank you. Good night.
Night.
Good night.